respected seniors, my dear colleagues, and our junior fellows. I am Dr. Mahendra Lodha. I am an additional professor in Department of General Surgery. On behalf of Department of General Surgery, I am presenting today's CGR. The topic for today's CGR is Metabolic and Bariatric Surgery. A topic which is close to my heart and which has given a new life, new specialty or new name and new options to a general surgeon and general surgery field. Before I start my talk, let us know how much the burden of disease worldwide. In 1948, WHO declared the obesity as a disease, and the WHO classified the obesity as a disease and gave the ICD classifications in 1948. At that time, lots of people were not still aware and they didn't recognize the disease, and that's why gradually the epidemics of the obesity is growing. Since last 1975, the obese population has grown 3 times. If you see the worldwide data, more than 1.9 million adults are overweight and 650 millions are obese. Our country is also not behind. We are at number 3 worldwide, and our obese populations is 1.35 million. And because of this obesity, 2.8 million deaths are happening every year. And despite of a huge number of obese person and overweight patients, the disease is being neglected at many levels, at the public level, at the medical fraternity level, and every level. And we are not able to cope with the epidemic of obesity. What happens once a patient become overweight or obese? The obesity is a gateway to the ill health. It leads to the lots of disease, whose list is very long. And if we say that what are the main disease which are associated with the obesities are the diabetes, non-alcoholic fatty liver disease, lots of cardiovascular disease, gallbladder disease, cancer is also not behind. Stigma also being faced by the obese persons or obese patients. There's an osteoarthritis, sleep apnea, all these happens and leads to increases the morbidity and mortality of the patients and reduces the quality of life of patients. There has been a lot of terminology which have been newly developed in association with the obesities. When patient who suffers type 2 diabetes, who is obese, the terminology is called as diabesity. And when complex diseases like dyslipidemia, hypertension, cardiac problem, diabetes are associated with the diabetes, it is called as the metabolic syndrome. It is a gamut of disease which leads to the metabolic syndrome. Coming to the definition of metabolic surgery, this is defined as the operative manipulation of a normal organ or organ system which achieves a biological result for a potential health gain. Here I would like to stress that the purpose is to gain the health. So it is not a cosmetic surgery. The bariatric surgery, this word comes from the Greek word that means obese, and lytic means obesity, weight loss. So it is called as weight loss surgery. So the liposuction, lots of people or patients who comes in our OPD, they ask that, does the liposuction is a weight loss surgery? No, it is not a weight loss surgery. It is a cosmetic surgery. If I do not mention the definition of a BMI, or we don't know the BMI, it's very, very important that we should know BMI, because this is the commonly used parameter or anthropometric measure which is being utilized by clinicians to categorize a patient as obese, overweight, or obese. The BMI needs to be mentioned, or it has a great effect because of the ethnicity also. We have because we are Asians and we have got a different parameters for the BMI. The parameters of BMI are less than the standard worldwide parameters, because we are at high risk of developing the obesity at the lower BMI, because we are skinny obese. We are having more risk of central obesity and we have more risk of the disease. The obesity management require a comprehensive management. It can be medical or surgical. It requires a teamwork, a lifestyle modification, dietary treatment, and a surgery is a best and a top of the all these options. The just before the October 2022, the world over the obesity guidelines which were being followed were given by the IPSO. They were led in 1991. And since 30 years, we were following that parameters also. This guideline says that all the patients who are having a BMI more than 40 kilogram per meter square, they should be advised or they must undergo a bariatric surgery. And a parameter BMI which is more than 35 with association of the type 2 diabetes, sleep apnea, obesity related cardiomyopathy, and severe joint disease. All these are were the indications of the patient who were candidate for a bariatric surgery. But on October 2022, the World Federation, the ASMBS and IPSO, they revised their criteria for the obesity surgery. The reason mentioned by was that since last 30 years, the obesity surgery has reached up to a certain extent. It has led to a good evidence that obesity surgery options are a good evidence-based procedure which can benefit a life of a patient. So we need to change, and they change their criteria for the obesity surgery for a patient. So the present criteria for a patient to undergo for a obesity surgery or metabolic surgery is any patient who is having a BMI more than 35 kilogram per meter square, regardless of the presence or absence or severity of the comorbidities. And a patient who has got a diabetes, the indications is even at the 30 kilogram meter squares, and a patient whose BMI is the range of 30 and 34.9, who had failure to achieve a weight loss despite of all medical and lifestyle modification. These are the candidate for the obesity surgery. These are given by the IPSO. It is an international federation of the surgeons of the obesity surgeons. What about the Asians? As I told that we are suffering from skinny fat syndrome. Our genetic makeup is different. Because of the YY paradox or the YY phenomenon, we have got a more central obesity. If you see this picture on the left side, the picture has got two persons. Both were scientists. The left side is in Yudkin and right side is sitting is in Yagnik. Both BMI is 22.3 kilogram per meter squares. But if you see the fat content in their body, which was measured by spectrophotometry, and we realized that the fat content were 3 times different in our Asian populations. That leads to that exposed to or that put us on a more risk for the obesity related disease and obesity risks. So there was a need to revise the BMI parameter for Asians, and the IPSO gave that we should reduce the BMI parameter by 2.5 kilogram per meter square. So the parameters for the Asians, or we can say for Indians, is the patient who has got a BMI of more than 32, they are the candidate. The patient who has got a diabetes, even at the 27.5 kilogram per meter square BMI, they must be or they should be subjected for the obesity or metabolic surgery. And for the patient who has failed to respond to all the medical parameter and lifestyle parameter, they should be subjected. A patient who has got BMI of 27.5 to 32.4 kilogram per meter squares. The good thing about all these guidelines is that these are not the guidelines which has only been endorsed by the surgical society. We would like to stress that all these guidelines has been also endorsed by the many non-surgical society worldwide, including the ADA, that is an American Diabetic Association, and International Diabetic Federations, because diabetes is a problem worldwide, and in our country we are the diabetic capital. So why to advise the metabolic and bariatric surgery? Till now, there are plenty of evidence or evidence-based evidence which are available in the literature, which says that it is the most effective and long-lasting treatment for the severe obesity. It improves, prevents, or resolves many related diseases like diabetes, heart disease, hypertension, sleep apnea, and certain cancers. It reduces the risk of certain cancer also. If you undergo a surgery for obesity, it reduces your chance of getting died because of the premature death because of obesity by 30 to 50%. So the parameters, the data are quite good, are in favor of the bariatric surgery. Needless to say that if a patient undergoes a bariatric surgery, he will lose his weight in 1 to 2 years by 6 to 77%, and he will maintain this weight till a 5 year. 50% of these patients will maintain this weight up to 5 years, and there will be reduction in the 89% reduction in the mortality in severe obese patient who had undergone the weight loss surgery as compared to the person who has not undergone a bariatric surgery. So the bariatric surgery will reduce leads to the remission of the disease, diabetes, hypertension, obesity-related sleep apnea, dyslipidemia, cardiovascular disease, approximately from 58 to 92% overall. So what you are thinking? So if you want to live long, if you want to live with obesity, decision is yours. If we weigh the risk of getting obesity surgery versus living with obesity, the risk, the side of the bariatric surgery is quite high. The risk of getting complications after bariatric surgery is less than 2%. Even risk of getting a death with the bariatric surgery is 0.1%. That means the risk of getting an operated for the bariatric surgery is as equal to you are getting a cholecystectomy or hernia surgery being done. So what does the number says? As per the IFSO 2019 published data, worldwide 8 lakhs patients every year goes for a bariatric surgery, and in our country it's approximately 20,000, and sleeve gastrectomy, which is approximately 10,000, a number in our country. So beside the parameters led by like in the numbers of the BMI, there must be certain all other parameter must also be fulfilled to get a good result or good outcome from a bariatric surgery. These things are like a patient must be motivated, he must have a good family support, and he must have undergone all the prior attempt to weight loss in terms of medical management, lifestyle modification, etc., etc. And he must be committed to a lifelong follow-up for the follow-up. And he must not have any psychiatric problem or any addiction like alcohol. So briefly, what are the contraindications for a bariatric surgery? There are 2 types of contraindications. One is procedure-wise. The Crohn's disease patients are relative contraindications for RYGB or malabsorptive procedures where the intestines is needed to go for surgery. For a sleeve gastrectomy, relative contraindications of Barrett esophagus or GERD and hiatus hernia, they are the relative contraindications for a sleeve gastrectomy. There are certain medical conditions like severe heart failure, unstable coronary artery disease, end-stage lung disease, active cancer treatment, portal hypertension, alcohol dependence, impaired intellectual capacity, patient could not take their own decision, or any contraindication to general anesthesia. These are the contraindication or relative contraindication for a patient to undergo bariatric surgery. Obesity surgery, as I told, is in teamwork. The team involves the surgeon, physician, endocrinologist, anesthetist, intensivist, psychiatrist, psychotherapist, dietitian, and bariatric nurses who take care of the preoperative, intraoperative, and post-op care of the patient. In our department, we do a thorough workup of the patient. We take a proper history, thorough examination of the patient, thorough referrals of the patients are being taken, and patient is being then subjected to the bariatric surgery. This is the chart which we used for our department to practice before a patient goes for a bariatric surgery. So coming to the history of the bariatric surgery, the history of bariatric surgery is not too old. If you go into the literature, we find that the first bariatric surgery, which was done in 1950, later on in 1965, the bypass schemes. But the scenario or the paradigm shift happens in 1990 when all these procedures before the 1990 were being done by the open procedure. That's why there were huge morbidity and mortality were associated with these procedures. But after 1990, with the development of the technology, optometrics, and the various other technologies, advancement in the staplers, laparoscopic techniques, all lead to the development of the minimal access surgery as options for patients to undergo a bariatric surgery. And since last 30 years, lots of procedure has been developed, and more than 90% of these procedures are now being done as a bariatric surgery. If we go into the history of the bariatric surgery, all the bypasses happens. If we go into the story of the bariatric surgery, the weight loss was a side effect of all the bypasses. So this side effect was being utilized as a procedure to give options for a patient who suffers from obesity like disease. So as I told, more than 50 procedures have been developed since last 1950 to 2023. But only 6 procedures which has been properly standardized, has been studied, have got evidence, like laparoscopic band surgery, sleeve gastrectomy, one anastomotic gastric bypass, Roux-en-Y gastric bypass, biliopancreatic divergence or BPD and duodenal switch operations. The above 4 procedures are most commonly used, and later 2 procedures like BPD and BPD, they are in developing phase, they are not being done in lot number. The 90% of procedures these 4 procedures are accounting for the more than 90% of the procedures. The bariatric procedures can be broadly classified into the restrictive procedure, malabsorptive procedures, or a procedure which has got both the mechanism like the restriction as well as malabsorptions. Coming to restrictive procedures, the procedures commonly being done are the laparoscopic adjustable gastric band, in which a band is applied around the upper part of the stomach, and a channel which is fixed into the skin, through which saline is being put into the port, which leads to the constriction or narrowing of the upper part of the stomach, and patient has got restricted capacity to eat, so that that leads to the weight loss. Another procedure which has emerged as a great procedure had led the number which has gone huge number, like sleeve gastrectomy. This is the procedure of the band procedure. In the sleeve gastrectomy, this is purely a physiological procedure. There is no anastomosis or no bypass, so there is no options or no complications in terms of malnutrition or the malnutrition related complications. There is low chance of nutrition deficiency. In this procedure, we remove the 80% of the stomach which is in relation with the greater curvature of the stomach, and which leads to the reduction in the capacity of the stomach, that is approximately 60 to 100 ml in nature, so that patient could not eat, and that leads to the weight loss. This is the most common procedure being done worldwide. Numbers are growing significantly, and in our country, this is also again a leading procedure in our country also. There are certain or various malabsorptive procedures also, like biliopancreatic diversion plus minus duodenal switch, Roux-en-Y gastric bypass, and mini gastric bypass. These are the malabsorptive procedures. The Roux-en-Y gastric bypass is again a commonly being procedure. In this procedure, we make a micro pouch which has got a capacity of approximately 20 to 40 ml only, and this pouch is being then anastomosed with the Roux loop of the intestines, that is approximately 150 to 200 or 180 centimeter away from the DJ junctions, and which function as a malabsorptive component of this procedure. So this has got a restricted as well as the malabsorptions options both in this patient, but this surgery is quite little bit more complex than a sleeve gastrectomy, and has got little bit more side effect than a sleeve gastrectomy. Again, this is also a BPD or biliopancreatic diversion with duodenal switch. This is also an endorsed procedure of the EPSO, and it is relatively reserved for a patient who are super obese, that BMI is more than 60, or patient who has got who needs a revision bariatric surgery, or who needs a more component of in terms of glucose control or sugar control or diabetes control. This is the photograph of biliopancreatic divergence. So which procedure to choose? Before patients undergo bariatric surgery, the procedures usually being, as I told, these 4 procedures are commonly being done. So which procedure to choose? It depends on the surgeon's expertise, it depends on the patient's BMI, it depends on the patient's dietary style, patient's need. All need to sit together and decide which patients will undergo which procedures. Sleeve gastrectomy, this is the simplest procedure. If we see the weight loss results of these 4 procedures, they almost are equivalent or almost equal in terms of percentage of expected excess weight loss. A patient will lose almost 26% to 40% of their body weight, and there is as the sleeve gastrectomy is having low nutritional deficiency side effect, but only side effect which I told may arise as a sleeve gastrectomy is a neo-gastric reflux or gastroesophageal reflux disorder. One anastomosis gastric OHGB, this is again a very simple procedure, but there is one anastomosis in terms of OHGB, so we can categorize or we can put on second number in severity of the operative procedure after sleeve gastrectomy. Only there is one anastomosis. In a Roux-en-Y gastric bypass, there are 2 anastomosis or 3 anastomosis are being done. So all these malabsorptive procedures has got malabsorptions as a side effect. So we have to consider as a dietary pattern of the patient, whether he is a vegetarian or non-vegetarian, or whether he will be educated or he will be ready to afford that high protein diet post-operatively for a long time. These all factors must also be considered before a patient you subject for a malabsorptive procedures. The good thing about the metabolic and bariatric surgery is that the most of these surgery, more than 90% of bariatric surgeries are nowadays being performed as a minimal access surgery or minimal access surgery or minimal invasive surgery. It can be done by either a single port, that means you will have a single incision on the body. It can be done as a multiple port, that means you will have a incision which will vary from a 5 millimeter to a 10-12 millimeter, that may be 3 to 4 incision on your whole tummy. These all procedures nowadays can be done by the robotic surgery also. And nowadays with further advancement, the endobariatrics or balloons and endoscopic sleeve also has been emerged as a new armamentarium in all these procedures. As I told, all these procedures are being done as a minimal access surgery. So patient has got, these are less invasive procedure, patient has got early recovery, mobility of the patient is good, reduced incidence of incisional hernia or wound complications that were there in the open era. So most of the patients can be discharged on a day care basis if the facilities or feasibility is there. So is there, as a surgeon, we know that we just do a cut, copy, paste for the intestines to create a malabsorption or to create a restriction. But this is not the only mechanism which is responsible for the weight loss, which is responsible for the comorbidity corrections. There is something else which leads to the messaging to the brain. Our brain get resettle or readjusted, our appetite goes down. There is something more than a restriction. There is a complete hormonal mechanism also is there. Due to these obesity procedures, body leads to development or changes in the various hormones like ghrelin hormone, hunger hormone, GLP and lot more. Our intestines is a largest endocrine organ of our body, which leads to the various hormonal change, which leads to the appetite change, and that is the mechanism for the weight loss. Because for the diabetic procedures, the control of the diabetes happens before the patient lose their weight. So there is definitely there is a different mechanism which exists other than the restriction and malabsorptions. The scenario is not so happy. There are some side effects which may happen to the patients, but the complications are not so great, not in severity. Like the complications can happen in the form of bleeding, infection, leakage, diarrhea, deep vein thrombosis, acid reflux, anesthesia-related complications, chronic nausea, vomiting, dilatation of the esophagus, inability to eat certain foods, infection, obstruction to the esophagus, and last but not least, the weight gain can happen if patient doesn't follow the regular life or regular exercise, or so the patient must go under exercise, and it can happen after some time. Few patients can have a weight regain. So post-operatively, the patient has to follow a certain dietary patterns. They have to take, for first week, they will take water, skim milk, strained creams, soups, low sodium clear broths, protein shakes, sugar-free drinks, mixes, and coffees and teas will be the for one first week. Later on, we can start the puree diet, and gradually we will start the patients on the soft food diet, and later on they can start with the trial and error. They can add on the large chunk also. Coming to the newer advancement which has happened into the field of the obesity surgery is in terms of endoscopic bariatric surgery or endoscopic sleeves. Nowadays, all the procedures which were previously or now it is being done by the transcutaneous route, now they can be performed with the route that is called a transoral route, or a GI physician or endoscopist can do this process that is called as sleeve, endoscopic sleeve, and the device is called as Apollo device, which is a new procedure which has emerged, and it is getting increasing number being done. The other procedures which we also have tried in our institute, like the balloon procedures, a sparge balloon, the patient who are not ready to go for the bariatric surgery, who are not able to lose their weight, they can have got options to get a balloon swallow, and they can lose their weight. 10 to 15 kg of the weight loss can happen to them, and it can act as a bridging procedure before the patient get a bariatric surgery done. Nowadays, Allurion balloon, it is a further advancement in the field of obesity, medical obesity treatment. There is a balloon which is as similar to we swallow a toffee, which is attached with a guide wire, which is attached with the Ryle's tube, which is being swallowed by the patient, and this balloon get dislodged into the stomach and get filled with the special characteristic kind of fluid, which is a patented technology of this company. And the beauty of this balloon is that this balloon get dissolved after 4 to 6 months of the duration. We have also tried this one balloon in our institute also. Coming to our experience, till now we had operated 13 number of the patients. The mean age of these patients were 46.84. 4 were male and 9 were female. The age distributions were among most of the patients were between the age of 40 to 60. The 9 patients were suffering from the diabetes, 8 were of the hypertensions, 2 were hypothyroidism, 1 was having a coronary artery disease, and OSA was present in 2 patients. Ventral hernias were present in the 3 patients. They really came for us to get an operate for the surgery. So initially we gave them options to weight loss, and there were 2 patients which were suffering from the BPH, and 1 was having a syndromic presence in terms of uterine agenesis. The preoperative BMI was in the range of 35 to 40 for the 3 patients. More than 10 patients were having the BMI of the more than 40 kilogram per meter square. The mean BMI was 45.23 kilogram per meter square, and mean current BMI after these patients undergone a bariatric surgery is 32.9 kilogram per meter square. The procedures performed by us, the 11 were the sleeve gastrectomy and 2 were the OAGB or one anastomosis gastric bypass. If we see the outcome of in terms of weight loss, this is being given in this stacked bar chart. The longest follow-up we are having is of 41 months, and shortest follow-up we are having is of 3 months, and mean duration of follow-up is 17.3 months. There is no major comorbidity has happened with these patients. Now, how we calculate a weight loss after bariatric surgery or any bariatric surgery? The weight loss is calculated in terms of percentage of excess weight loss or a percentage weight loss. These are the two parameters are being utilized for the documentation purpose of patient who has undergone a bariatric surgery, and this is being calculated by a given formula which is known as divine formula. Coming to our follow-up, in our patients, surgical success defined our patient which has gone bariatric surgery. The present BMI is in the range of 20 to 30 for the two patients. The patients which has patient who has got more than 50 to 60% of weight loss are three patients, 60 to 70% BMI loss in terms of 4 patients, and 70 to 80% loss for 1 patient. Our mean percentage excess weight loss is equal to 50.7%, which is all equal to the standard parameters of national worldwide. The 8 patients had a percentage of all the 8 patients has BMI or percentage excess weight loss in terms of 50 BMI within the follow-up period, and 9 patients out of the 5 patients who had undergone less than 50% of bariatric or weight loss have got a follow-up of approximately 9 months to 26 months of follow-up. Therefore, I can say that if we complete our pending follow-up, the present surgical success rate can reach up to the 61%. But given our small sample size, we cannot say that our data is a limited data. Coming to the diabetic improvement or hypertensive improvement, we can see 5 patients out of 9 diabetic patients, they have got complete response to the complete response to the bariatric surgery, and they have got stopped taking their anti-diabetic drugs. And the 3 patients has stopped anti-hypertensive drugs. 1 patient, there were no change in the diabetic status, and 3 patients, there were no change in the anti-hypertensive medications, and 3 patients from diabetic group were having a partial response. The reduction in the diabetic drug came out, and for the 2 patients, the partial response in terms of anti-hypertensive drug goes down. If we review the literature, we can see the percentage excess weight loss in ranging from the 40% to the 62%, and our percentage excess weight loss falls in the range of 50.7% excessive weight loss, and our surgical success rate is 61%. That is almost equal to the international parameters. These are few photographs of the patient who has undergone with us a bariatric surgery. This was my first patient which underwent a bariatric surgery, was suffering from the myalgia, obesity, hypertension, and type 2 diabetes. Her current weight is approximately 65 kg, and she has a very good quality of life after bariatric surgery. This was a young lady who was suffering from the PCOS, had undergone a bariatric surgery, and she has lost 40 kg of weight after 1 year of follow-up, and since last 1 year she is not under a follow-up. This was a lady also has got a very good effect of the bariatric surgery, and this is a young patient, 18-year-old boy who was having already amputated limb. He was in handicap. He was having a BMI of in the range of 35, more than 35, and we operated, and he's also doing good in terms of weight loss procedures. The weight loss surgery is not the only options. We have to treat the obesity in terms of as a comprehensive care or as a good umbrella care for the obesity patient. The 4th March is being observed as a World Obesity Day. We celebrated this Obesity Day by conducting the various walkathon, and the public awareness programs was also conducted. Our medical students did the skit in the OPD area to get aware our publics regarding the obesity and obesity-related complications and obesity disease. Coming to the take-home message, the obesity surgery is an effective procedure for the weight management and the comorbidity resolutions. A multidisciplinary approach to the obesity is essential for the comprehensive care of the obesity in the form of obesity clinic. We have to work under one roof where the facilities of or the expertise of a dietitian, endocrinologist, physician, and surgeons are sitting together, and they can handle the obesity and obesity related disease under one roof. What we have seen in our this 3-year journey, that we found that the obesity isn't ignored at our institute also. We less frequently find that obesity being written as a diagnosis in our prescription or in our indoor prescriptions. The ICD-10 code classification for the obesity and obesity related disease is an E66. Let us start writing a diagnosis of obesity in our prescriptions to do the good for the obesity and obesity related disease. We have to work together, we have to work hard, as we all know that we are suffering from a huge number of population which is obesity, which has reached in terms of epidemics, and the data are going worse day by day. This is a photograph which I took 2 days back. We are very busy, we are always houseful in our OPD, but it's a shameful that if we fail to advise a right treatment for obese patient, and a patient who comes or who visits our institute and fails to return back, and if he returns back without seeking a proper advice in terms of weight loss. This gentleman, he was suffering from severe obesity. His BMI was more than 45, and he was having a severe obesity related obstructive sleep apnea. He was visiting frequently to our ICU, our respiratory clinics, but he was never advised obesity or obesity related advice or treatment. So my request is that let us treat the obesity as a teamwork and achieve a good control on the obesity or good management of the obesity, and let us fight obesity together. We are running obesity clinics at our institute in the room of 524. Kindly please refer us the obesity patient. We will manage your obesity patient properly. I will acknowledge for today's presentation Dr. Spurti Setti, who is our JR in our department, who prepared all my slides and side works. And I will feel if I don't acknowledge the anesthesiology department, who are the main department who help us in anesthetize the patient, who takes care of post-operative care of our patients, endocrinology department, gastro departments, dietitian, medicine department, cardiology, pulmonology, and nursing officers who do help us in caring our obese patients. These are the reference for my today's presentations, and thank you for hearing me. House is open for the question and answer. Thank you.
Well presented. I hope half of this hall will be at your 5 to 4 after 1 hour. But always remember, obesity is a nutritional disease. It occurs only when you eat more and exercise less. And hence, treatment by removing the normal organ, what you are doing, that telling the patient eat less. If you can motivate the patient to eat less with the normal stomach, he doesn't require the surgery. So basic problem lies with our attitude and motivation to treat. You are telling that lifelong follow-up is required. How many patients we really tell patient what to eat, what to exercise lifelong? And who does it? So most important thing is motivation and our emphasis, right? So of course, metabolic surgery, you are doing it, you are surgeon and we are the physician. So rivalry will go on, it will be lifelong. So I always feel that I tell my patients that if you can do it, and they lose patient, they're the literature. I can tell you, I can give the slides of the vice versa literature. that with simple nutritional management, you get the same results we are getting after the surgery. But it has to be emphasized and done meticulously throughout the life. I always say obesity is not a one-day disease, 1 month disease, 1 year disease. It is the lifelong disease. Hence, management has to be lifelong, whether surgery, after surgery, before surgery, whenever it is to be done. But well presented, taking the steps. I hope you get a lot of patients. Rajasthan is a rich country.
Thank you, sir. So I absolutely agree with your comment. The obesity, I agree with you that definitely obesity is a lifestyle-related disease, but there are few subsets of patients who may need it, who really need it, and we have to select the right patient. That's the, as an institute, we have to practice in a right manner, or we have to work as a research group, sir.
Interesting presentation. So liposuction, is it, what is this?
So liposuction is just nothing. They do suck the fat which is present on the parietes or on our abdominal wall.
So this is not obesity.
This is not an obesity surgery. This will not lead to a metabolic change in your body. This will lead you just a cosmetic appearance, or this will remove your external fat.
Yeah, excellent presentation. Just wanted to highlight that you mentioned an umbrella care with regards to the obesity management. That is one point which needs to be highlighted. Second, you mentioned it leads to rewiring the bariatric surgery with change in the hormonal patterns, which leads to significant weight loss. Just wanted a point of view from your side with regards to bariatric surgery, whether a resurgery is required in some patients, or a second surgery is required in your patients, maybe not in your experience in literature. Has that happened in these patients, or some patients which regain another surgery is sort of helps?
Yes, sir. I agree with you that, sir, the umbrella care is needed for a holistic management of obesity. Coming to the point on the resurgery or redo surgery or weight gain, definitely it is there. It will happen after a few years, but it is not so high. It can happen if a patient is not a good compliant patient. So that's why or it can be sometimes a two-stage surgery. If a patient's BMI is super obese, the patient BMI is more than 50 or more than 45, then you can do a two-stage surgery also, considering the patient's risk for the anesthesia and all these parameters.
Morning, sir. Thank you for increasing the awareness regarding obesity. Myself, Dr. Lokesh Agarwal, I am from Department of Surgical Gastroenterology. I would just like to add that non-alcoholic steatohepatitis is coming up in a big way, and obesity is primarily responsible for it. We did a prospective study of over 300 patients where we found that a weight loss significantly improved liver fibrosis and steatosis both. This is coming up in a big way, as now NASH is a leading cause of liver transplant worldwide. So this weight reduction, obesity having an impact on NASH is definitely to come up in a big way. So I would just like to add that the word metabolic surgery is therefore added to this obesity surgery because of these reasons. Second, I would like to add that sleeve gastrectomy and gastroesophageal reflux disease, now we are doing antral resecting sleeve. Hence, gastroesophageal reflux disease is not a significant contraindication or is not a problem post-sleeve because of this procedure of antral resecting sleeve.
Absolutely, Dr. Lokesh, I agree with you. I told that it's a relative contraindication. If your patient has got a significant esophagitis or GERD symptom, then because after a sleeve gastrectomy, either a GERD symptoms may worsen or there may be new GERD symptoms may be there. And definitely a NASH is definitely a problem in our populations, and that will be, and we can use the bariatric surgery as a bridging procedure for an osteoarthritis patient who are suffering from the NASH, or patient who are going for the liver transplant, renal transplant, or cardiac transplants.
Very nice presentation, sir. And definitely obesity is a very common we see all around us, and this is a complication, lead to the complication of in every specialty. So I just want to add one thing is that because everywhere and every part we see a negative impact of the obesity, and we should take attention over that. But one interesting finding or one interesting information about the obesity is that when the patient is on hemodialysis, those who are obese have an overall good prognosis. That is very interesting things because might be the malnutrition that is these patients are suffer from, and these obese patients are better to cope with the malnutrition per se. So these patients, when we compare with those who are not obese and those who are obese, the prognosis is slightly better. This is the point that is I just highlighted. But definitely, obesity is a very important disease itself. It's had a lot of complications. And just want one question from you is that it is only the surgery is indicated when the patient have a complication related to this obesity, or just a BMI you consider for taking the patient for the surgery? Because a lot of the patients have hypertension, diabetes, sleep obstructive sleep apnea syndrome, and even the patient have a proteinuria. So these are the complications of obesities that can need to be attention, and surgeries might be indicated. But without complication, are you confident or are you comfortable in taking the patient for the surgery?
Yes, I agree with you, Dr. Rajesh. Thank you for your comment. The guideline has clearly indicated that any patient whose BMI or Asian origin, BMI more than 35 with or without any comorbidity is directly candidate for a bariatric surgery, and who has done their all the efforts, who has undergone a medical treatment, who has done their 2-year effort for the weight loss, they are definitely candidate for the bariatric surgery. For a diabetic patient, 27.5 BMI is a cutoff point for the diabetes, because diabetes is our burning problem in our country. We are a diabetic capital.
Did you face any complication, minor, major? And I think slide missed somewhere all spine degenerative diseases, either due to posture or due to weight. So that is missing, that we face day in and day out. Spine degenerative diseases, most of them are due to posture, bad posture maintenance, or weight, overweight, obesity. So spine degenerative diseases all are related to obesity also, most of them. So what were the complications that you encountered?
So in our small series of patients, we have not encountered any complications related to the spine or any complications related to the surgery.
Spine, surgical complications.
No, we don't have faced any major surgical complications. One or two patients, when we inquired, that they have encountered occasional nausea, vomiting, because they were not trained for the post-bariatric dietary management. They have to adjust their behavior. They have to take a small meal and frequent meal. These are the things we have to educate the patient post-bariatric surgeries.
I mean that spine disease also improves by weight loss.
So there are definite, I don't have idea regarding the spine surgery, but definitely osteoarthritis, patient who undergo for the joint replacement, the many orthopedic society, they recommend that the patient should go for the bariatric surgery before they undergo for a joint replacement surgery. They were definitely a post-bariatric surgery, the result of the joint replacement surgery will be better. So the bariatric surgery can work as a bridging procedure for the pre-transplant patients, for the patient who are undergoing joint replacement surgery, and patients who are even an infertile patient, a female gynae patient. We will find lots of infertility patient. The obesity management can lead to some chance of success or getting pregnant.
Dr. Mahendra, very nice presentation. So are we like overemphasizing BMI? Because are we obsessed with the BMI? Because BMI is a surrogate marker and may not reflect the true obesity. So are you using any other marker that is for defining obesity, or any other studies on this area?
So worldwide, the BMI is the only parameter being utilized for the obesity surgery guidelines, but there are definitely other parameters like the waist and thigh circumference ratios. These are also there to measure the obesity. And BMI is not the 100% accurate parameter to measure the obesity, but it is the commonest used parameter.
Basically, these Asian parameters of the 27 and 23 has come from the Indian studies, including our study of the population. Basically, obesity and weight. Obesity is, we are defining, but BMI, as sir is told, is a surrogate marker. What is obesity? Is excess of fat In
Yes,
the
sir.
man, more than 25%, in the female, more than 30%, and that is measured by the DEXA, which is available in our institute. So that is the better marker. And why this BMI is different from the West? Because at the BMI of the 23 and 27, we get excess of fat, which is equivalent to the Western counterpart of the 23 and 30. So that's why cutoff has changed, because the excess of fat then defines the obesity rather than the weight. So what sir is telling that we at present gold standard is underwater weighing, but at present this DEXA measurement is the accepted measurement of the excess of fat in the body, because somebody weightlifting, somebody bodybuilder may have the 35 or 30, but he will might have the excess weight, as you have seen in the Yaznik paradox. Yeah, Yaznik is in the KM hospital. He also works on this, and Yutkin is the UK, and both are the partner. And this photo was of the DEXA, not of the spectrophotometer, which you are showing. This was the first DEXA, which was done in the UK, and that was done by the DEXA, and the photograph is of that DEXA machine of both. So, we all work on the same area. So, as sir is saying, that it is the fat amount in the body that is very, very important, and the comparative BMI has come from the fat rather than any other metabolic parameters.
Point well taken, sir. Thank you, sir.